Hello everyone, this is Dr. Gobind Rai Garg, and in this video we will discuss the questions and answers which were asked in NEET PG May 2022. So I've got some recall questions, so we will be discussing that. Okay, so starting with the first question. A patient was given intravenous botulinum toxin and the patient died. Mechanism of botulinum toxin overdoses. So basically they are asking what is the mechanism of action of botulinum toxin, and we discussed in our lectures also. If we see, this is the synapse, acetylcholine is produced and stored here, then it is released, and finally it work on receptors. So what botulinum toxin does is it inhibits the release of acetylcholine from the neuron. It inhibits the release of acetylcholine, and we discussed how to remember that this structure, it look like a bottle. If you see, it look like a bottle. Yeah? So botulinum toxin, the name says bottle. So botulinum toxin will hold the bottle from here, so prevent the leakage. Yeah? So it inhibits the leakage. That means we can say it inhibits the release of acetylcholine in the synapse. Okay. So coming to the question, mechanism of botulinum toxin, inhibit release of acetylcholine, that is the answer. Inhibit reuptake of noradrenaline, wrong, that is done by cocaine or tricyclic antidepressants. Blockade of postsynaptic nicotinic cholinergic receptors, no, it is not N blockers and M blockers. M blockers are neuromuscular blocking drugs like the drugs which are ending with curium or curoniums, and N blocker drugs are ganglion blockers like trimethophan, hexamethonium, etc. Inhibit entry of acetylcholine in the vesicle, that is done by visamicol. Vesicle may choline cannot enter. Okay, the answer is inhibit release of acetylcholine. Okay, moving to second question, very easy, repeatedly asked several times, drug of choice in paracetamol overdose. Yeah, so you all know that, but quickly describing the main important thing, paracetamol is metabolized to form a toxic compound called as NAPQI. N-acetyl benzoparaquinoamine, and this has very high affinity for sulfidal, which is normally present in the body in the form of glutathione. Liver is producing glutathione. If that is not working properly, like an alcoholics or patient with liver disease, then this become free. Or if it is taken in overdose, it become free, then it can cause toxicity, the major side effect being liver damage. And how to treat toxicity? We have to give exogenous source of sulfidal group, and that exogenous source is N-acetylcysteine. Remember, cysteine is a sulfur containing amino acid, so it must be containing sulfidal group. So N-acetylcysteine will provide the sulfidal group that will treat the toxicity. Okay, moving to other options, dopamine, hydralazine, furosemide, they are very easy. They are the other drugs, they are not antidote of anything. So N-acetylcysteine is very easy answer in this question. Hope everyone has made that correct. Okay, so moving to next question. A young female presented with left-sided severe throbbing headache, pulsatile headache, associated with nausea, vomiting, photophobia and phonophobia. So you must have made the diagnosis. Yes, you are correct. It is migraine with aura. Migraine with aura. Which of the following can provide immediate relief to this patient? That means which is the drug used to treat acute attack of migraine? We know the drug of choice for acute attack of migraine are NSAIDs. Aspirin like drugs are drug of choice, and if it is not controlled by then we are using triptans like sumatriptan, etc. Alternative to this are ergotamine like drugs, but drug of choice for severe headache will be triptans. Okay? So if we see the options, sumatriptan is the answer here. The other three drugs, propranolol, topiramate, flunarizine, all are used in migraine, but they are used to prevent migraine. They are used for prophylaxis of migraine, not for acute attack. So for acute attack, only one drug is given in the option, sumatriptan. Now sumatriptan, quickly revising, it is important drug. It is 5-HT1B1D agonist. Sumatriptan is 5-HT1B1D agonist. Okay. So we have some newer drugs which are used in migraine. Newer drugs used in migraine include the drugs which end with the ditan, like lasmiditan. The drugs which end with the gepants, like olcegepant, rimegepant, ubrogepant. The drugs ending with the gepant. And third, we have a group of monoclonal antibodies. Now, what is important? Lasmiditan, it is 5-HT1F agonist, whereas gepants, They are calcitonin gene related peptide antagonists. Antagonist of receptor of calcitonin gene related peptide. And all these two groups, they are given orally and they are used for acute attack of migraine. Okay. On the other hand, monoclonal antibodies like aranumab, galcanezumab and fremanezumab. As we all know, these are monoclonal antibodies ending with mab, and because they are big in structure, they cannot be given orally. So all of these are injectable drugs. They are injectable, not effective orally, and they are used for prophylaxis of migraine when the other drugs fail. Okay, so that is important about new drugs in migraine. The question was easy. It is migraine with aura. Drug of choice for acute treatment are triptans like sumatriptan. Okay, moving to next question. A patient on digoxin therapy accidentally consumed 8 tablets of digoxin 0.25 mg. So simply it is digoxin overdose. 2 hours later, the patient presented to emergency with heart rate of 54 beats per minute. So that is bradycardia and ECG evidence of third degree AV block. So we know in overdose, digitalis can cause bradycardia, it can cause blocks, so that is seen in overdose. So what is the immediate management? So what we see for immediate management of digoxin overdose, first of all, we will stop digoxin. We will look at any interacting conditions like whether there is presence of hypokalemia or hypomagnesemia or hypercalcemia. We will look for whether other drugs are present like it can thiazide diuretics can cause toxicity, and other drugs like verapamil, amiodarone, they can cause toxicity. Yeah. After that, we have to treat arrhythmias. Now we have two methods. If there are tachyarrhythmias, we can use lignocaine or phenytoin. They are used in tachyarrhythmias. And DC cardioversion, we all know, is the last step in tachyarrhythmias. On the other hand, for bradyarrhythmia, either we can give atropine. If atropine is not given in the option, then we have to neutralize the toxicity by giving antibody, and that is digoxin immune FAV portion of antibody. The other name of this is digibind. So digibind is normally used for severe digitalis toxicity. So this is used in this case because it is bradyarrhythmia, and other drugs mentioned, they are not used in bradyarrhythmias. Okay, so the answer is digibind. Okay, moving to next question. Of 82-year-old patient presented with acute episode of breathlessness. So person comes with dyspnea. Chest X-ray shows pulmonary edema. So pulmonary edema, so must be some cardiac cause. History reveals that patient has uncontrolled hypertension. So uncontrolled hypertension along with we can say pulmonary edema. So giving indication of yes, congestive heart failure. Patient is not taking medication regularly, so all the more chances there will be CHF. So what should be the management? So basically for CHF patient with pulmonary edema, what we will do? For acute CHF patient, what we will do? We can give inotropic drugs, but if there is low cardiac output. Second, we can give vasodilators. So in this person, if you see salbutamol cannot be the answer because this breathlessness is not due to respiratory cause. It is due to cardiac cause. Intravenous antibiotics plus oxygen is usually not required. There is no sign of infection. Although we can give, but that is not the immediate treatment. The most important will be to treat the CHF. We have to give a vasodilator like nitroglycerin. So intravenous nitroglycerin will be the treatment of choice in this case. Basically, we have to treat congestive heart failure. Easy question. Okay. Moving to next question. This is about a new drug which is not so new nowadays because I have been teaching this drug since 5-6 years now. Which of the following act by inhibiting PCSK9? PCSK9, what is PCSK9? It is pre-protein converting subtilisin caxin type 9. First of all, what is the function of this protein? The function of this protein is it help in breakdown of LDL receptors. So क्या होता है कि LDL receptor को बहला फुसला के lysosomes में ले जाती and where the LDL receptor is degenerated, it is broken down. So if we inhibit PCSK9, LDL receptor will not be broken down. So the level of LDL which is taken by these receptors, that will reduce, because receptor is not broken, so it can take up more LDL from the blood, so there will be less LDL in the blood, so we can use the drug as hypolipidemic drug. It is used for homozygous, familial homozygous hypercholesterolemia, and the drugs are evolocumab and alirocumab. Two drugs are there, and you can remember the name. These are monoclonal antibodies against PCSK9, and their name contains OC, means they are used when there is over cholesterol, excessive cholesterol. They are hypolipidemic drugs. Atorvastatin, we know it is HMG-CoA reductase inhibitor. Ezetimibe inhibit the intestinal absorption of cholesterol, and lomitepide, the name says it is microsomal triglyceride transport protein inhibitor. It inhibits the microsomal triglyceride transport protein. Okay, so evolocumab is the answer in this case. Okay, moving to next question. A patient presents with pituitary tumor that overproduces growth hormone. So there is excessive growth hormone, symptoms of acromegaly. Surgical removal of the tumor was incomplete. So what is the first line treatment of this patient? We all know acromegaly, we can use two type of drugs for acromegaly. Normally we use drugs like somatostatin analogs, or called as octreotide, or we can use cabergoline like drug which can decrease growth hormone. So among these, only one is in the option, that is octreotide, so that is the easy answer. If we see the other drugs, leuprolide, neferalin, goserelin, all of them are GnRH agonists. When we give them continuously, they will decrease gonadotropin releasing hormone, that will decrease gonadotropins. So gonadotropin will be reduced, so they are used for those conditions where we want to decrease gonadotropins, like precocious puberty. But here it is nothing to do with them. So here the answer is very simple, octreotide, which is a somatostatin analog. It is a long acting somatostatin analog, and the name says it is ending with the tide, means it is a peptide. So it cannot be given orally. So we give this drug subcutaneous. Cabergoline we can give orally, whereas octreotide is given subcutaneously. Mostly we prefer octreotide. Okay, moving to next question. A male presents with protrusion of chin, excessive sweating, impaired glucose tolerance, and enlargement of hand and feet. So these two, protrusion of chin, enlargement of hand and feet, they give the indication of acromegaly. Yes, so another question on acromegaly. Which of the following drug is growth hormone receptor antagonist used to treat this condition? We know acromegaly is due to excessive growth hormone. So we have two mechanisms to treat acromegaly. The one we discussed earlier, that means the drug which can decrease the level of growth hormone, and we have two such drugs. One is somatostatin analog, that is octreotide, and second is cabergoline. Okay, these we discussed earlier. Now the new strategy is to block growth hormone receptor. That means growth hormone is present but it cannot work. So we can give growth hormone receptor antagonist, and the name of that receptor antagonist is pegvisomant. Pegvisomant, the name itself says it is somatotropin. Somatotropin is the other name of growth hormone antagonist. So it is a somatotropin antagonist, means growth hormone antagonist. So can be used in acromegaly. And the first three letters PEG, polyethylene glycol. So when we add PEG or polyethylene glycol to any drug, it becomes long acting. So it is a long acting growth hormone antagonist. In Hindi you can remember, peg लगा के आदमी लंबा चलता है, दवाई तो चली जाएगी. So it is a long acting. And the remaining two letters tell the major side effect. It causes visual field defects. The main side effect of pegvisomant is visual field defects. Okay. So coming to the question, which is growth hormone receptor antagonist? So they are asking about receptor antagonist. So the answer will be pegvisomant. The name says somatotropin antagonist. Okay. The other drugs, octreotide, we already discussed. It is used in acromegaly, but not the growth hormone antagonist. Cabergoline is also used, but not the antagonist. And also GPANT we discussed earlier. It is GPANT. It is used in migraine. It is CGRP antagonist. CGRP. So you can say GE means gene peptide antagonist. Calcitonin gene peptide antagonist. Okay. Moving to next question. A 40-year-old diabetic female presented to emergency with abdominal pain, vomiting, and recent onset confusion. A diabetic patient coming with these symptoms, what you are thinking of? Yes, diabetic ketoacidosis. So on examination, irregular breathing is there, kusumul breathing, and dehydration pointing toward acidosis. Okay, blood sugar is high, 539, very high blood sugar, and there was presence of ketone bodies in the urine. So that confirms a diabetic ketoacidosis. BP is low. So everything is pointing toward diabetic ketoacidosis. So what is the next best step? So what will you do in diabetic ketoacidosis? Yes, two main things. One, dehydration we have to correct. Second, insulin is less, so we have to give insulin, so that will correct the ketoacidosis. Both ketone bodies as acidosis will be corrected by insulin. And which insulin will you prefer? That can be given IV. And which insulin is given IV? Yes, regular insulin. So the best treatment will be intravenous fluids with regular insulin. IV fluids with regular insulin is the treatment of choice for diabetic ketoacidosis. But when we give insulin, it shifts the potassium intracellularly, so hypokalemia chances are there. So keep on measuring the potassium level, and if it falls, we can supplement potassium also. Okay, so the answer is IV fluid with regular insulin. Moving to next question. A female presented with galactorrhea. Galactorrhea occurs due to which hormone? Yes, prolactin. So her urine pregnancy test was negative. Prolactin is high in pregnancy, but pregnancy is not there. So MRI of the head revealed a large pituitary tumor. So which tumor is more likely to be? Yes, prolactinoma. So likely to be prolactinoma. Patient refused to undergo surgery. Which of the following is the best drug for treatment of this patient? So basically, which drug will decrease prolactin level? We know in hypothalamus there is a hormone called as prolactin inhibiting hormone. And what is the other name of this hormone? This hormone is nothing but dopamine. So hypothalamus secrete dopamine, it go to pituitary and inhibit the release of prolactin. So if we give from outside dopamine receptor agonist, it can do the same thing. So dopamine agonist, it will stimulate the dopamine receptors in the pituitary, and that will inhibit the release of prolactin. So we can use that in prolactinoma. So the question is, which of the following is dopamine receptor agonist? And we all know dopamine receptor agonist is bromocriptine. So bromocriptine, it can be used in hyperprolactinemia. It can be used in patient in which prolactin secretion is more, like in case of tumors. Clear? So the answer is bromocriptine. Octreotide is growth hormone receptor antagonist. Not antagonist, growth hormone receptor decreases growth hormone. Promethazine is antihistaminic and clozapine is antipsychotic, not related at all. So simple answer, bromocriptine. Okay, moving to next question, another very easy question. A patient comes with opioid poisoning and has severe respiratory depression. We know opioid can cause respiratory depression. I hope you remember the mnemonic sacra. So actions of opioid: sedation, analgesia, constipation, respiratory depression, euphoria, and meiosis. So this respiratory depression is caused by opioids. So which is the most effective drug for treatment? So basically we have to block this opioid receptors so that the respiratory depression is reversed. So simple answer is, what is a drug of choice for acute opioid poisoning? And that we all know is naloxone. Naloxone has to be given IV, but highly effective drug for opioid poisoning. Fomepizole, we know it is used for alcohol poisoning. It is alcohol dehydrogenase inhibitor. Flumazenil is benzodiazepine antagonist, and naltrexone is given orally. It is used for maintenance in acute opioid poisoning. In case of acute poisoning, we use naloxone. Then to maintain that, we give naltrexone because it is long acting. Okay, moving to next question. So this is a question which is frequently repeated question, 5-7 times already it has been repeated. A patient on antidepressant therapy presents with elevated body temperature, dilated pupil, palpitations, low BP, EC shows tachycardia, broad QR complex, and right axis deviation. Can you think of which poisoning we are talking about? Which poisoning? Yes, we are talking about tricyclic antidepressant poisoning. Remember, tricyclic antidepressants have very strong anticholinergic properties, and these anticholinergic properties can result in elevation of body temperature, mydriasis, tachycardia. So all these are features of anticholinergic. Then they have alpha blocking property that can cause hypotension, low BP in this case. Then these drugs, they can cause arrhythmias because they are sodium channel blockers. They can result in arrhythmias, and the most dangerous thing, they can result in acidosis. Yeah. So all these features, they are seen in TCA poisoning, and this TCA poisoning, all these are seen in TCA poisoning, and TCA poisoning, the best treatment is first to correct acidosis. If we correct the acidosis, the arrhythmias mostly subside automatically because they are precipitated by acidosis. So the best treatment we discussed several times is intravenous sodium bicarbonate. Correct the acidosis, other factors will automatically fall into place. Second, if there is very strong anticholinergic property, we can use drugs like physostigmine. Physostigmine, it is drug which is cholinergic drug. To reverse the anticholinergic poisoning, we can give cholinergic drug. Okay, so physostigmine is later, but main thing is sodium bicarbonate. Okay, moving to next question. A patient present with tremors, rigidity and bradykinesia. Very easy question. What is the diagnosis? Yes, it is Parkinsonism. Parkinsonism. So which drug can be used in Parkinsonism? Easy question. Among these four drugs, which is anti-Parkinsonian drug? So one by one we will discuss. Salazilin, we know it is MAO-B inhibitor used in Parkinsonism. That is the answer. MAO-B inhibitor used in Parkinsonism. Donepezil, it is acetylcholinesterase inhibitor which is used in Alzheimer's disease. First line drug, or we can say drug of choice for Alzheimer's disease, is donepezil. Remember Dr. Gobind drugs? Donepezil, rivastigmine, galantam. Then fluoxetine is drug of choice for depression. It is SSRI used in depression, and haloperidol is an antipsychotic drug. Okay, so very easy answer is salazilin. Okay, moving to next question. A child born by normal vaginal delivery developed repeated attacks of flexion of neck over the trunk, flexion of neck and jerks in the hands. So what is this known as? What is this known as? Yes, this is called as salam seizures. Salam seizures. Flexion of neck and jerking of hands. Clear? Salam seizures. ECG shows the presence of hips arrhythmia. So hips arrhythmia is present, salam seizures are present. The diagnosis is, yes, it is infantile spasms. Infantile spasms. So which drug is the drug of choice for infantile spasm? You all are aware of. Drug of choice is, yes, ACTH is the drug of choice for salam seizures, infantile spasms. And second drug we can use is vigabatrin. Vigabatrin can be used, but drug of choice is ACTH. So there is no confusion, only one option is given, ACTH, that is the answer. Okay, moving to next question. 11-year-old boy presented to emergency with vomiting. Parents give history of consuming 10 to 15 tablets of ferrous sulfate. So this is iron overdose. A day before, he has taken last day and today he is coming. So what is the antidote of iron for treatment of this patient? First of all, if a patient comes with any poisoning, first thing we give is, we try to prevent the absorption of that substance from GIT. So we can induce MSS, vomiting we can induce, or we can give activated charcoal so that further absorption is decreased. But now activated charcoal will not have that major role because it's already one day, most of it must have been absorbed. So now we need to give antidote, and the antidote for iron we all know is desferrioxamine. The name itself says ferry in the name, so desferrioxamine is antidote for iron poisoning. Very easy. Dimercaprol, the other name is BAL. We know BAL is mainly used for bismuth, arsenic and lead poisoning, but remember BAL is contraindicated in iron poisoning. Remember, BAL is contraindicated in two poisonings, one is cadmium and second is iron, and you can remember from the mnemonic CAFE. So Ca means cadmium, and Fe means iron, ferrous. Okay, so BAL is contraindicated in cadmium and iron poisoning. You can remember CAFE में BAL नहीं होना चाहिए. अगर CAFE में BAL दिखने लग गया तो कोई नहीं आएगा. Okay, so BAL is not given in cadmium and iron poisoning. D-penicillamine is mainly used for copper poisoning. It is drug of, we can say, first line drug in treatment of copper poisoning and Wilson's disease. Okay, so the answer is easy, desferrioxamine. Moving to next question. This also we discussed in a lecture several times. A DVT patient, deep vein thrombosis patient, was started on anticoagulant therapy. Next day, the patient present with features shown here. So what is the feature shown here? So there is thrombosis, hypercoagulation. Hypercoagulation, in simple words, it is called as dermal vascular necrosis. Dermal vascular necrosis. Sometimes it's shown here in the toes, then it is called as purple toe syndrome. Okay. Now, it can be caused by two drugs. One is warfarin, second is heparin. But the difference is, heparin causes heparin-induced thrombocytopenia, which can manifest like this later on, minimum 5 days after starting therapy. Here the patient is coming second day, so the drug is warfarin. Warfarin causes hypercoagulation early on. So So warfarin induced hypercoagulation. This is the features, clinical features. So answer is warfarin. Okay. And moving to other option, rivaroxaban, we all know it is factor 10A antagonist, oral anticoagulant drug. Dabigatran is thrombin inhibitor, direct thrombin inhibitor, another oral anticoagulant. Okay. Heparin is injectable. Other three drugs given in the option are oral drugs. Okay. Moving to next question. A patient of COPD was given intravenous aminophylline therapy. Aminophylline, theophylline group, and patient developed diuresis. What is the mechanism? So, what do you need to say? Theophylline or aminophylline group of drugs, they have some side effects which can be due to one of the two mechanisms. One, because they are phosphodiesterase inhibitors, that is their main mechanism. They inhibit metabolism of cyclic AMP. And second, they can be adenosine A1 receptor antagonist. Adenosine A1 receptor antagonist. So phosphodiesterase inhibition, it can lead to GI side effects like nausea, vomiting, etc. It can lead to headache, and it can lead to arrhythmias. So the three side effects which can be due to phosphodiesterase inhibition are GI problems, headache, and arrhythmias. Whereas A1 antagonism, adenosine antagonism, it can result in arrhythmias. So arrhythmias has dual mechanism. It may be due to phosphodiesterase inhibition or it may be due to adenosine antagonism. Then diuresis and seizures. The three side effects which are due to adenosine A1 antagonism. So how you can remember adenosine? Just write adenosine antagonism. So adenosine antagonism causes three side effects, which is A for arrhythmias, D for diuresis, and E for epileptic seizures. Obviously it is not epilepsy but seizures. So these side effects are due to adenosine antagonism, whereas GI side effects and headache is due to phosphodiesterase inhibition. So why diuresis occur? Now we know it is due to adenosine receptors, and easy one because phosphodiesterase is not given in the option. So it's very easy to remember. So answer is adenosine receptor antagonism. Okay. Moving to next question. A female with ovarian cancer was on cisplatin therapy. So this is wrong, it's she. She presented to hospital with several episodes of vomiting. So we know anti-cancer drugs can cause vomiting. After giving an antiemetic drug, the patient developed dystonia. So basically after giving antiemetic drug, the patient developed dystonia. So most likely drug. We know dystonia is due to which? Yes, it is due to D2 blockade. And which antiemetic drug mainly act by blocking D2? Yes, we all know these are metoclopramide and domperidone. And what is the difference between metoclopramide and domperidone? Metoclopramide can cross the blood-brain barrier, whereas domperidone cannot. So metoclopramide can enter the brain, block D2 receptor, and that can lead to dystonias. So this is the repeat question. I think last year also this was asked. In that question it was asked like an intern gave a drug which lead to dystonia. So here directly dystonia is given. So repeat question, answer is metoclopramide. And be very careful. We know drug of choice for cisplatin induced vomiting is ondansetron. Do not mark ondansetron. They have not asked drug of choice. They asked which antiemetic drug causes dystonia. So answer will be metoclopramide. Okay. Moving to next question. A pregnant female with urinary tract infection took antimicrobial. The baby of this female developed tendon rupture and arthropathy. Must have been sure now which drug can cause, if we given pregnancy, can cause tendon damage and cartilage damage. Yes, it is fluoroquinolones. What is the likely mechanism of action of this antimicrobial drug? So they are simply asking what is the mechanism of action of fluoroquinolone. We all know it is, yes, DNA gyrase inhibition. Fluoroquinolones are DNA gyrase inhibitors. Drugs like floxacin, ciprofloxacin, norfloxacin, moxifloxacin, these are fluoroquinolones. So folic acid synthesis inhibiting drugs are sulfonamide group of drugs. Mycolic acid synthesis inhibitor are anti-tubercular drugs like isoniazid. DNA gyrase inhibitor is the answer here. And DNA inhibitor, there are many other drugs which directly work on DNA like rifampicin. Rifampicin basically working on RNA and indirectly act on DNA. So RNA polymerase inhibitor rifampicin. So answer here is DNA gyrase inhibitor. Okay. Next question. A 48-year-old female patient presented with tingling and numbness of the fingers. So symptoms of peripheral neuropathy. Patient is chronic alcoholic and was recently started on anti-tubercular treatment. So this is giving the hint that anti-tubercular treatment has started, and that resulted in tingling and numbness sensation. So most likely cause should be, yes, it is isoniazid. Isoniazid cause deficiency of vitamin B6, that is pyridoxine, that can lead to peripheral neuropathy. And so if we give pyridoxine, that can be treated. So answer is pyridoxine or vitamin B6. Now although numbness and tingling can be due to peripheral neuropathy like symptoms, numbness etc., can be due to B12 deficiency also. And chronic alcoholics may have B12 deficiency, but there is no other hint given, like patient is malnourished or other features are not given which can point toward B12 deficiency. Yeah? So B12 deficiency may be the cause if antitubercular treatment has not been started, but here the examiner is pointing toward the antitubercular treatment, so that means there is isoniazid should be the cause. Okay, so pyridoxine is the prophylaxis as well as treatment of peripheral neuropathy due to isoniazid. Clear? Next question is very easy, simple, very simple. In MDR tuberculosis, but which shows a resistance, we discussed several times. There are many cases of anti-tubercular drug resistance. So we divide the tuberculosis in mono drug resistance, then we divide it into poly drug resistant, rifampicin resistant, multiple drug resistant, and extensively drug resistant tuberculosis. I told you in my lectures also that treatment of this is not that important for PG entrance, but when we will say this resistance, to which drugs the mycobacterium resistant, that is commonly asked. Clear? So previously the question asked was on XDR TB, now it is on MDR TB. So what is monodrug resistance? When the mycobacterium is resistant to any one of the first line oral drugs, except rifampicin. So first line oral drugs we all know are HRZE. So except rifampicin, because we have separate category for rifampicin resistance. So if the bacteria is resistant to either isoniazid or pyrazinamide or ethambutol, it is called as monodrug resistance, any one. Polydrug resistance is more than one of these three drugs. That means among HZE, if the mycobacterium is resistant to H and Z or H and E or Z and E, then it is called as polydrug resistant, but not rifampicin. Rifampicin resistance is the term used when the bacteria is resistant to rifampicin but sensitive to isoniazid. It is not resistant to isoniazid, only to rifampicin, then we will say it is rifampicin resistant. And MDR, when it is resistant to both isoniazid and rifampicin. When it is resistant to both of them, then we will say MDR TB. And extensively drug resistant TB, the term used is when the mycobacterium is resistant to both isoniazid and rifampicin. That means minimum MDR. Plus it is resistant to any one of the minimum one of the fluoroquinolones, and plus minimum one of the injectable drugs. Then the bacteria is said to have, TB is said to have XDR TB. Okay, so here very easy. In MDR TB, so very easy, isoniazid and rifampicin resistance. That is the answer. Okay, moving to next question. A patient presented with hyperkalemia. Which of the following drug can cause intracellular movement of and thus decrease in extracellular potassium? So which drug will increase the movement toward the cells? That means it will decrease in the blood. Clear? And we all know beta 2 agonist like salbutamol and insulin. हमने बताया था salbutamol से और insulin से potassium डरता है. Clear? So whenever they are present, potassium is afraid, so it will quickly go inside the cells and वहां जाके छुप जाता है. Okay, so beta 2 agonist and insulin, they can be used in hyperkalemia. But if you see the options, beta 2 agonist or insulin is not given. But if you see the options carefully, beta 2 agonist is given, and that is epinephrine. Remember, epinephrine other name is adrenaline, and we discussed A for adrenaline, A for all the receptors, alpha 1, alpha 2, beta 1, beta 2. So by stimulating beta 2 receptor, it can increase the movement of potassium toward the cells, inside the cells. So potassium can decrease in the blood. The other options, atropine, lactic acid, glucagon, cannot cause this thing. So answer is epinephrine. Okay, moving to last question. Which drug has least adverse effects on pleura? Yeah. So pleural or pulmonary fibrosis type of side effects, this is not caused by which drugs? So we all know bromocriptine. Bromocriptine is an ergot derivative. Methysergide, the name contains ergot. So these are ergot derivatives, and ergot derivative can cause fibrosis, pleural fibrosis, retroperitoneal fibrosis, pulmonary fibrosis. So these are associated with pleural side effects. The nitrofurantoin also can sometimes cause pleural fibrosis. So the remaining drug is metformin. It is not commonly associated with the pleural fibrosis. So the answer is metformin here. Metformin do not cause pleural side effects. Other three drugs are associated. Okay. So these are the important questions asked in the NEET PG 22. So if you have any more doubt, I am available. Thank you very much.